Chris, some water.
And I think I'm all right, yeah. Hello, everyone. Cool, so welcome to the second session. What a privilege it is to follow Anne and Gwen and to be part of this community. I haven't been to this meeting for a little while, but it does feel like a reunion. So all those people I'm seeing when I'm running past saying, I think they're worried about my slides not arriving, which was about 15 minutes ago, I intend to catch up. Thank you for inviting me to be part of IFOMPT, and it's slightly intimidating for me because I'm not a manual therapist. Is that okay? However, I do find humans very, very fascinating. And particularly I find myself quite fascinating. And I often find myself saying something and then thinking, why did I say that? Does anyone else relate to that? Yeah, and I find other humans even more fascinating than me. So it's a good field to be in when you're dealing with people with pain, and my particular interest is people with chronic pain. As a scientist, I'm convinced that it is impossible to know what you're thinking and why you're thinking things. So you need to be very careful to identify and eliminate as many of the biases as you can. I think it's really important for all of you to know what conflicts I bring into this room and I bring into my career. So I'd like you to take a look at my disclosures. Now, normally when you're at a conference, it works like this. And here are my disclosures. Oh, people, they didn't go fast enough. I'll try it again. Here are my disclosures. Oh, that's very slow, isn't it? Anyway, they don't show them long enough in my view. I have conflicts of interest here, so over the last 6 years or so, they're some of the organisations who have supported my travel, if you like, to a meeting, who might have paid me a bit of money. And that will come into my research decision making, and I can't help that because I have a very complex brain, and so does everyone. And the influences that are behind what we think and what we decide are sometimes very difficult to grasp and to see. Relevant to that is this question, and I guess the brief that I was given was really along these lines of let's get the pain biology into patient care. But I'm also really interested in what is the biology that's sitting underneath patient care, so a two-way relationship. And this is a series of studies that I was really excited by when I did my undergraduate physiotherapy degree. And I've constructed the next images based on, primarily on this review, but a whole body of work by Braithwaite and Cooper looking at analgesia with placebos. And this would be the amount of analgesia you get if you give someone an aspirin or a placebo. And this would be the amount of analgesia you get if you do nothing at all, which should make our training in the clinical sciences a bit easier because we could just teach people how to do nothing at all and we would still have an effect of some kind. We're better off branding the aspirin. So if we put the aspirin in a branded box, we're going to get a better result than if it's not branded. But not surprisingly, if we brand the placebo, we also get a better response. So if we're doing a completely inert intervention, we should brand it. Give it a brand, because we'll have a more substantial analgesic effect. So what Braithwaite and Cooper suggested, and there's a very large body of research now to replicate their work and really to consolidate it, to suggest that whenever anyone gets pain relief, there are different contributors to their pain relief, ranging from natural history, is just what would happen anyway, the drug effect, in here it's in orange, the act of taking a pill has an effect. And this is the thing that really sparked my interest. I thought, really? Why does the act of taking a pill have an effect? And the brand effect. So that's an analgesic mediator, which I think is really, really interesting. And just so you know that this is not just a few studies, I don't expect anyone to necessarily be able to read that, but the point of this is is to illustrate just how much research there is here. Each of the rows of this column talk about groups of studies. For example, this one of them up there is an analysis of 416 randomised placebo-controlled trials. Right, so this is a massive amount of research underpinning some of these sorts of findings of the effects of inert treatments. And here's some of the things that come out, which I think are interesting. If you inject an inert molecule, it will have a greater effect than if you swallow that inert molecule. Capsules are better than tablets. Capsules that you can see into and have lots of little red balls in them are better than capsules you can't see into. Capsules delivered with the left hand are more effective. No, that's not true. Okay, I went a bit too far. So here we can compare exactly the same molecule, both in the active treatment and in the inert treatment. The same treatment, delivered in two different ways, has a different impact. I think this is quite interesting. Can you raise your hand if you believe that you are a better than average therapist? It's only the men who put their hand up. That was interesting. Very interesting. So let's apply this to some of what we do. For example, two clinicians do exactly the same treatment. Now, this is extremely unlikely, actually, but let's just pretend for a moment that that could happen. And one clinician gets a better analgesic effect than the other clinician. I hope you'll agree that that's a reasonable possibility. So let's say these are the two clinicians. On one side, we have someone who's getting quite a large treatment effect here, and then on the other side, we have someone who's having a small treatment effect. And as far as I can see from the literature, in most of what we do, not just in physiotherapy, but really across the interactive treatment disciplines, most of what we do, the actual thing we do has a small effect. But the change in someone's life is potentially quite large. So the package that we are delivering or engaging in can be really effective, but the thing we're labelling it, the part of that we're pinning everything on, has a small effect. And I think I believe the data are pretty compelling to justify that position. And it's tempting for us to call all of that green stuff there that's not natural history the placebo effect. Now, I think placebo is a daft idea, actually, because what it's saying is that there is an effect of an inert thing. And inert things don't have effects, so this is a nonsense phrase, if you like. And I think placebo effects don't actually exist. I don't think there is actually a placebo effect, and I'll explain to you what I mean by that. We now have empirical data that suggests that the better looking you are, the better your analgesic effect. So we have one clinician here with dashing good looks, and the other clinician, I showed the photo of the other clinician to my 14-year-old daughter, and she said, "Did they know you took that photo?" I said, "Really? Charlotte, have a good look at that." She's confused, and then I had to go, and she understood straight away. There's empirical data that the perceived intelligence of your clinician, their eloquence, their expertise, affects pain relief of whatever they do. So hopefully you can see the thing we thought was the placebo effect is getting smaller. And the only reason it's getting smaller is that we're understanding more of the interactions that are happening and the cues that have some sort of meaning to the brain of the person who is suffering, if you like. What about the clinician on the left who sort of drops their Mercedes-Benz keys on the table in front of you? Can I help you? And then you notice there's also a set of BMW keys on the same key ring, and you're thinking, wow, they must be good. Or the person on the other side who has their push scooter in the back of the office. Doesn't really instill you with confidence. Now, I don't know of empirical data that compares the analgesic effect of owning a Mercedes or a push scooter, but the principle, I hope you agree, is there.